You know, the human nervous system, it's gotta be the most complicated thing we know of. So when something goes wrong with it, the symptoms can be just, well, completely baffling. How in the world do you start to piece it all together? Well, that's exactly what we're going to get into. Welcome to a masterclass in clinical reasoning, the Neurologic method.
I want you to think of it like this. You're a detective, and every patient, they're presenting you with a new mystery. Their nervous system, it's a black box. You can't just pop the hood and look inside. But you have all the tools you need to figure out exactly what's happening, and crucially, where it's happening. Your entire job is to uncover the truth that's hidden inside.
Every great detective, right? They need a protocol, a system they can rely on to crack any case, no matter how weird it seems at first. And for us, that system is the Neurologic method. It's this structured, really logical approach that takes what feels like chaos and turns it into pure clarity. So what is this method? It really just boils down to a few key steps. First, and this might sound obvious, you have to confirm that a neurologic problem actually exists. Okay, check. After that, the entire investigation is guided by two massive questions. The first and most important one is, where is the lesion? This is all about anatomy, pinpointing the exact location. And only after you know the where can you move on to the second question. What is the lesion? That's the pathology, figuring out the nature of the culprit itself.
Every investigation starts with gathering clues, and your number one source, your most valuable asset, is the patient's story. Taking history is so much more than checking off boxes on a form. You have to think of it as interviewing your primary witness. You are listening, really listening, for the narrative of the crime.
And you know, the timeline is one of the biggest clues you'll get. Was the onset sudden, like happening over seconds or minutes, like a gunshot? That just screams a vascular event, something like a stroke. Or was it more subacute, kind of unfolding over days and weeks? That makes you think about an inflammatory process, maybe an infection. Or has it been this slow, grinding, progressive decline over months, maybe even years? That's the classic signature of a slow poison, like a neurodegenerative disease. You see, the timing tells a huge part of the story. Now, here's something you're gonna run into all the time. Your witness, the patient, will often use really vague language. A patient saying, "I just feel dizzy," is the absolute classic example. That doesn't give you much to go on, does it? As the lead detective on the case, it's your job to dig deeper, to clarify what they really mean by dizzy. Because dizzy could mean vertigo, a real spinning sensation, which points you toward the vestibular system. Or it could be lightheadedness, which makes you think more about circulation. Maybe it's actually imbalance, a problem with steadiness, which points toward the cerebellum. Or they could even be misinterpreting their double vision, diplopia. Each of these answers sends your investigation down a completely different path on the neurologic map. Precision here is everything.
Okay, so you've got the witness testimony, you've got the story. Now it's time to go to the crime scene. The neurologic examination, that is your systematic search for hard physical evidence. Evidence that will either back up the story you just heard or maybe contradict it.
And this is not just some random list of tests you run through. No way. It's a methodical, really a head-to-toe search for objective signs that are going to test the theories you've already started to form. You're on the hunt for physical evidence the patient can't just make up. You know, subtle weaknesses, changes in reflexes, or specific patterns of sensory loss that will corroborate their story. And remember, you're not just looking for isolated little clues here and there. You are hunting for patterns. Does the weakness affect just one side of the body? Does it spare the face? Are the reflexes super brisk or are they absent? These patterns are the fingerprints, the smoking gun, that will ultimately reveal the location of the lesion. A huge part of our investigation is about quantifying the evidence we find. So take this, for example, the muscle strength scale. It lets us put a number on power. We can grade it from a 5, which is full, normal strength, all the way down to a 0, which is no movement at all. This is how we take a subjective complaint like, "My arm feels weak," and turn it into objective, solid data that we can put in our case file. All right, let's get to the really cool part. This is where we take all the information we've gathered, the story from the history, the hard evidence from the exam, and we take it all back to the office. It's time to pull out our map of the nervous system and pinpoint the exact location of the problem.
You see, all that work, all that detailed history taking, and the careful, meticulous exam, it has all been leading up to this single moment. The whole goal is to put all those clues together to confidently answer that first absolutely critical question: where is the lesion?
And this table right here, this is basically your master map. It's your cheat sheet for localization. Let's walk through it. Say you found some mixed weakness and sensory changes, but the head and face were totally fine. Where does the map tell you to look? Boom, right there, the spinal cord. What if you found weird eye movements, plus weakness on the opposite side of the body? The map points you straight to the brainstem. This is exactly how the patterns of evidence lead you to a specific location.
So, you've gathered your clues from the witness. You've found the physical evidence at the crime scene. You've pinpointed the location on your map. Now it's time for the final act. It's time to identify the culprit and solve the case for good. See, just by knowing the where, you have dramatically shrunk your list of possible causes. This list, that's your differential diagnosis. Think of it as your lineup of likely suspects. Before, you might have had 100 possibilities. But now that you know the problem is in the peripheral nerve, for instance, you're down to maybe 3 or 4 prime suspects. Localization makes the whole challenge manageable. So at this point, you've built a really strong case. You've narrowed it down to just a few top suspects. Now it's time for confirmation. And this is when you call in the forensics lab. For us, that means our ancillary tests, things like an MRI or a CT scan, maybe some blood work or even a lumbar puncture. These are the tests that confirm what your detective work already told you.
And that is how you write the final report. You see how it all flows? You start with the patient's story. You combine it with the hard evidence from your exam. You use that powerful combination to pinpoint a location. Then you get your forensic confirmation from your tests. And all of that leads you to the final diagnosis, the solution. Every single step builds logically on the one before it. Look, this whole method isn't just some academic thing to memorize for a test. It is the fundamental skill of our specialty. Every single patient that walks through your door is a new mystery, a brand new puzzle just waiting to be solved. The clues are always there. The only question is, are you ready to find them?